So the first talk is by Dr. Shachi, Basic Understanding of Pathology and Microbiology for Ophthalmologists.
Good morning to all. I'll be starting my talk. Basic understanding of pathology and microbiology for an ophthalmologist. I have no conflict of interest and no financial disclosures. As ma'am rightly pointed out, post-surgical endophthalmitis is one of the most devastating complications of intraocular surgery. Entry of infectious agent into the vitreous cavity is a prerequisite for endophthalmitis to develop. Majority of the cases of post-operative endophthalmitis develop in the first post-operative week. Delayed endophthalmitis, that is after 6 weeks, usually is caused by fungi or low virulent organisms. Occasionally, the signs and symptoms may be subtle and misleading in the early stages, so a high index of suspicion is warranted. Coming to the pathogenesis, in the era of ICC, there existed a direct communication between the anterior chamber and the vitreous cavity. With ECC and PCIOL implantation, the low virulent organisms can still become sequestrated in the capsular sac. The IOL can act as an intraocular foreign body. There are increased intraocular manipulations with ineffective sterilization techniques. There can be chronic irritation of the iris and ciliary body by the IOL. Also, the electrostatic forces on the IOL can attract microorganisms from the periocular tissues during insertion. Pathogenesis of postoperative endophthalmitis can occur due to surgical trauma, which leads to breakdown of blood aqueous barrier and initiate the postoperative inflammation. The IOL acting as a foreign body leads to foreign body reaction and release of macrophages with synthesis of cytokines, which leads to synthesis of prostaglandins with further breakdown of blood aqueous barrier and renewed inflammation, including fibrin formation. Also, interleukin 1, interleukin 6, prostaglandin E2 synthesis by the residual lens epithelial cells at the margin of capsulotomy can come in contact with the IOL and cause more synthesis of other cytokines and induction of prostaglandin E2 synthesis, which leads to further breakdown of the blood aqueous barrier, renewed inflammation, production of collagen 4, and capsular phimosis. Coming to pathology, the risk of developing endophthalmitis is directly related to size of the inoculum, virulence of the organism, access to vitreous, and perioperative antibiotic use. As we all know, the avascular vitreous is a better culture medium than aqueous. There occurs inflammatory response from surrounding vascular structures due to breakdown of blood aqueous and blood vitreous barriers. Bacterial infection causes diffuse liquefactive necrosis of the vitreous and invasion of polymorphonuclear cells, which is a hallmark of suppurative necrosis. On gram staining, there are numerous bacteria in the vicinity of necrotic debris. Coming to the actual pathology, what happens inside the vitreous, there are inflammatory exudates in the vitreous, which lead to liquefaction and posterior vitreous detachment, which leads to abscess formation in the vitreous. There is inflammation in the iris, ciliary body, also in the retina, which lead to separative necrosis, and retinal perivasculitis with lymphocytic infiltration can occur. All these findings may not be visible to us because of the dense vitreous inflammation. All this leads to cyclitic membrane formation along the posterior chamber. That membrane contracts, causing traction on the ciliary body, which leads to cilio-choroidal detachment. That can cause hypotony, and inevitable phthisis may occur in untreated cases. So the microbiology is very important. Acute postoperative endophthalmitis following cataract surgery is most commonly caused by coagulase negative staphylococci in around 70% of the cases. Staphylococcus aureus is causative in around 10% of the cases. Streptococci around 9%. Gram-negative bacteria in around 6% cases, and other gram-positive bacteria and enterococcus around for the least amount of cases. This data was supported by the EVS study. Coming to most common pathogen causing, most common organism responsible for intraocular surgical endophthalmitis, post-cataract surgery is coagulase negative staphylococci, that is Staph epidermidis. After intravitreal injections, it could be coagulase negative staphylococcus or streptococci. In post-traumatic endophthalmitis, either coagulase negative staphylococci, bacillus, streptococci, gram-negative bacilli, and rarely fungi may be responsible. Endogenous endophthalmitis is most commonly caused by Klebsiella pneumoniae, Staph aureus, streptococci, and candida. In bleb-related or glaucoma filtering surgery-related, either streptococci or Haemophilus influenzae are associated. Post-keratoplasty, candida can cause endophthalmitis. When the gram-negative organisms are responsible in post-surgical case, post-cataract cases, usually the most commonest organism is Pseudomonas, followed by Proteus, Haemophilus influenzae, Klebsiella pneumoniae, E. coli, and Enterobacter species. Role of microbiology laboratory. A clinical diagnosis of infectious endophthalmitis constitutes a medical emergency. Lab should guide us in the selection of the most appropriate antimicrobial therapy. Standard microbiological procedures include smear preparation for specific stains, followed by direct plate inoculation of selected culture media. Both aqueous and vitreous cultures are recommended in endophthalmitis. Sensitivity of the culture, vitreous is more important than aqueous alone. The culture sensitivity of the vitrectomy cassette fluid passed through a millipore filter is higher than vitreous biopsy obtained by a needle and syringe. So after we obtain the specimen, we usually subject it to gram staining, acid-fast staining, and KOH mount. So in gram staining, usually the gram-positive bacteria occur purple in color as opposed to the gram-negative, which are pink in color. And acid-fast bacteria also appear purple in color. Non-acid-fast are blue in color. And KOH mount is just a preparation on a slide viewed under a high magnification microscope for identification of fungal hyphae. Common culture media usually employed are blood agar for bacteria and fungi, chocolate agar for aerobic organisms, Sabaroth dextrose agar for fungi, thioglycolate broth is usually used for anaerobic organisms, and brain heart infusion media is employed for fastidious fungi. All the culture media should be kept for at least 2 weeks before labeling it as a negative or no growth. There have been recent advances in diagnostic method which may offer earlier and more accurate identification of common organisms. Those include PCR, DNA microarrays, multi-TOF mass spectrometry, and PNA FISH. To summarize, post-cataract surgery endophthalmitis most commonly occurs in the first post-operative week. The commensals of the skin and conjunctiva, that is coagulase negative staph, propionibacterium, and cornybacteria, are the most commonly involved. Ocular surface and skin cannot be completely sterilized by any perioperative antibiotic or antiseptic. The immune system possesses ability to clear a small burden of relatively avirulent microbes, as evidenced by the low prevalence of endophthalmitis. Gram staining, AFB, and KOH are a quick guide to initiate treatment. Thank you for your